Okay, so a couple things. We are going to finish skeletal system today, and that will be where your test leaves off. Okay? I already posted a quiz for you. Did you see it?
Yes.
24 questions. Open book, collaborate with your friends. Realize that what I'm trying to communicate to you is that's what you will need to do closed book by yourself, right? But you're not there yet. You've got some time. You got like 5 days before you're there, okay? So I gave you some examples of the kinds of skeletal system questions that you would see. Also remember that on this first test, only this first test, you need to bring your device because you will have 10 top hat histology questions. Only the first test. I don't use top hat on any other test, just so that you can actually see them and blow them up and like all of that kind of stuff, so you can get a good view on it. So bring your device. When is your quiz due? Sunday. Yes. 5 of you did not get it done last time. So pay attention to the due date, and your top hat starts counting down, right, on your phone, doesn't it? Yeah, it does. You just didn't look. What?
I don't have it on my phone.
You can just put it on. It counts down on your computer now too. So and you can change your answers and all that kind of stuff. So you've got it set up that way. The reason that it closes on Sunday is because as soon as it closes, the right answers populate, and then you've got that time to review them, right, and to make sure, like, to check your knowledge and all that kind of stuff. So I know that we've said it before, but repetition is really the soul of teaching. So tell me what the test covers. Histology, skeletal system, and anatomical terms. Yeah, right? Those 3. Yeah? Go ahead.
We have the whole class to work on, right?
Yes. Mm-hmm. You do. Whole class. One of the many reasons that I'm really glad that they went away from Monday, Wednesday, Friday scheduling, because then you only had 50 minutes to take the test. Now they're Tuesdays, or now it's just Monday, Wednesdays. Do you guys have any questions that we need to cover?
Format of the test, and that's a lot of multiple choice. Is there any essay?
Mostly multiple choice, some written. There's no true essay on the first test except the bonus, because you haven't done an essay for me yet, so I want you to have the opportunity to get some feedback before it like counts for you or against you. So the bonus will be essay, but there'll be some labeling or putting things in order or that kind of stuff. Some like part where you won't be able to make a B if you can't do anything but multiple choice, right? You could probably pass it, but you won't be able to make a B or higher if you can't do anything but multiple choice, right? And as the semester goes on, you get a little bit more written because you're good at it at that point, and a little less multiple choice. Go ahead.
So when we do the 10 questions on the top hat, so we're going to do part of it on the paper, and then I'll have my phone, and I just...
Top hat's just going to be running the entire time you're in class, and you can do the 10 questions whenever the hell you want to.
Okay. So we don't like write the answer on
Nope,
paper.
you do it on top hat and get it into top hat, right? So you can probably do it just like any time in the beginning or the end or whatever the hell you want to do. It doesn't make any difference. So it doesn't take that much time, right? That makes sense? Now, anybody in here had me before? You have. Okay. Tell them what to study for my test. She's not had me for anatomy before, but she's definitely had me before. What do you say?
Everything in the packet.
Yeah, every single bit of the notes or anything that the notes refer to. Do I tend to, and you will trust her more than you trust me, do I tend to take things from other places without telling you that I was going to? No. I can defend every damn question on the test. I can show you where it came from, or I have recordings of when I talked about it. So, I'm going to win that argument. I'm going to. Okay, does that make sense? But, I mean, it's a lot, but it's like less than a book, right? It's less than the textbook a lot. So, everybody cool? Okay. So, quiz, and then test. And then after we finish skeletal system today, which we'll finish in like 30 minutes or so, we are going to start on muscular system. Muscular system is not on this test, it's on test 2. The reason I'm going to start on it today is A, we have time, and B, it's going to prepare you for your hardest lab week, which is next week. Next week is your hardest week of lab. It's appendicular muscles. It's a lot. You're going to be overwhelmed. You'll be fine though. It's going to be just like the skull was last week. Does the skull seem slightly more doable this week than it did last week? Okay. With muscles, that'll take 3 weeks. But it's okay, right? So next week you are going to do, it's fine. It's all right. You'll be all right. Just realize everybody's in there suffering with you. So the next week you will do appendicular muscles, and then you'll do axial. The reason we do appendicular first is because they're hardest, and then it gives you more time to absorb them before the practical. So you do appendicular and then axial, but axial is easy comparatively speaking, so you have time to review with appendicular, and then you've got a little bit of review time, and then you're practical. So it gives you more time with those. So we do the hard ones first so that you'll get through them. Don't cry. Well, if you do, just don't cry forever. Just cry and get it out, right? A little stress hormones, getting them out. You'll be all right. But I'm going to get you started on it today because I'm going to give you some organizing principles that will help lab make sense when you get there next week. Okay? All right. So last thing that we wanted to talk about skeletal system was just osteoporosis, right? Or that's the last thing that we left off on. And then we're just going to do a little bit about joints, and we're going to use joints to lead into muscles. Cool? Okay, so last thing about osteoporosis is we didn't talk about prevention yet. So what can you do about osteoporosis? Well, you could go back in time and have better genetics. That ship has sailed. You could be a dude. Sorry, not going to happen. Okay? Or you could do some behavioral changes. One of them is exercise. Exercise stresses your bones, increases osteoblast activity, and decreases osteoclast activity. And you will get a thicker skeleton the more you exercise when you're in your exercising years, right? And then you'll start losing from there. Walking is all you need to do, right? For your hips and your legs and your spine. That's all you need to do. You don't need to run. Running is fantastic for your cardiovascular and respiratory system. It is hell on your joints. And it starts to be problematic as you get older. It is not bad for you. I'm just saying that there is a cost to it eventually, but a lot of times it's outweighed by the cardiovascular benefits and the respiratory benefits, but it's hard on your joints. Walking isn't hard on really anybody's, most people's joints. What about your upper body? Your upper body weightlifting really helps. Women should not be afraid of weightlifting. They tend to be afraid of weightlifting, but it's really good to build your skeletal system. And here's the other advantage to weightlifting that sometimes women don't understand, is that the more muscle mass you have, the higher your metabolism. Which means that you get to eat more, which is literally what we all want to do. I want to eat more, but be really attractive, right? Right? And also rich. But I don't know how to accomplish all those things at the same time. Obviously, just doing my best unless it's inconvenient, right? Just like you. Go ahead.
So I've been debating this with my son for a few years. He's a teenager. He knows everything. He is actually super bright. But anyway.
Yeah, so is mine. But he thought he invented the air conditioner yesterday.
I know. Mine's going to own an island. But anyway, I know.
Hopefully he's benevolent.
So he believes, like, if I go to the gym and then same store that night or the next day, that means I have injured myself. And I'm like, no, you have to rip apart the muscles to rebuild them.
Well, that's a fizz question. You actually have to do micro strains in your actual skeletal muscle tissue in order to cause protein synthesis. So tell him he's in the neighborhood of correct, but not correct. And then he can actually read primary literature to find out. Yeah. Okay. Go to scholar.google.com. Look up muscle tears, look up muscle regeneration. He will realize that he is not the smartest person in the world. Probably not even in the room, depending on the room, right? If you're always the smartest person in the room, what do you need to do? You need to change rooms, right? That's what you need to do, right? Okay? So maybe it's just because he's in high school and there's a bunch of freaking sloths, right? I thought I was brilliant in high school, but I was surrounded by dumb rednecks. That's all it was. And then I went to college and I was like, oh, I'm okay, I guess. And then I went to graduate school and I was like, does everyone know I'm an idiot? And then I've been there ever since. Okay, so he's kind of right. All right, so what else can you do? Oh, by the way, swimming, it's a fantastic cardiovascular and respiratory exercise. It doesn't really help with bone mass, though. Why?
Because you're grabbing no weight.
Yeah, because you're not putting much stress on your bones because you're taking most of the gravitational pull with the actual water. So swimmers, Michael Phelps, he didn't just swim, he also lifted weights, right? Okay, so he did a lot of other cardiovascular things. Okay, what else can you do? Well, you need to make sure that you got all the stuff that's necessary to maintain a skeleton. Adequate nutrients, right? Calcium, protein, vitamin D, all the vitamins related to cell division. We tend to pay attention to nutrition at certain points in our lives and not continuously. In college, you don't usually pay attention at all. You're like, ramen is 75 cents, I am going to eat that, right? It doesn't have a whole hell of a lot of vitamins. You'll probably survive. Stop smoking. If you're a smoker, it's bad for you. And I know you needed to take this class to hear that, right? There's no good part about smoking. Almost every other drug, with the exception of like crack and meth. Yeah, meth has some good side to it. Like alcohol, a little bit of lowering of blood pressure, right? Especially in combination with red wine. But smoking, there's no good story to it. It zaps antioxidants from your system, and it actually ends up diminishing your skeletal system. Part of the reason, I think I told you guys that my mom, did I tell you my mom shrunk when so my mom died relatively young. She died younger than I was. And she had a cancer related to smoking. The last year of her life, she couldn't really eat. But in addition, she lost massive amounts of bone mass. And they said that was related to not just her cancer, but also her smoking. So her bone really diminished. Smoking, and then if you're a postmenopausal woman, some women choose to do hormone replacement therapy. Add estrogen and progesterone back. That's not without risks, FYI. If you have a family history of breast or ovarian cancer, then your physician needs to know that before you do hormone replacement therapy, because there's certain forms of breast and ovarian cancer that can be exacerbated by hormone replacement therapy. Not all of them. So it's just a conversation you need to have. And there's actually a genetic test you can do to figure out if that's the one that you have. And then what about treatments? Fluoride helps, believe it or not, not just for your teeth, but also for your bones. Calcitonic, right? That should help, shouldn't it? Tone down your blood calcium by depositing it into your skeletal system. And then there's some drugs that actually increase osteoblast activity and decrease osteoclast activity. Fosamax is one of them. When that came out, I don't know, maybe 10 years ago or so, it was still patented, and it was so damn expensive. For 4 pills, 1 per week, $800 a month with insurance. Now it's not patented any longer, it's cheaper, but now there's also a better version that is more expensive. So you will figure out, if you haven't already, and you probably have, that in this country, because of the structure of our healthcare system, you get entirely different care if you are wealthy and or have better medical care than if you are not. And that is not true in most westernized countries. It is not true in most westernized countries. And it doesn't have to be true here either, just so you know. There is a voting booth. You can vote. I keep voting, but I don't think mine's hooked up to anything. Because everything I vote for, the opposite thing happens, and then sometimes propositions pass, and then the legislature just says, nah, I don't think so. It's funny how that works. It's not funny, right? It's pissing me off. Okay, so articulations. So the last thing that we're going to do on skeletal system is talk about joints. And you can talk about joints in excruciating detail if you want to. Because if you go into PT or OT, you're going to end up really learning, if you go into PT, you're like, oh, I'm a physical therapist that specializes in the hands. You are going to learn a hell of a lot more about joints than we teach in this class. So I just want to give you an intro to joints, just like what general categories of joints exist. So this is in Chapter 9, but just because it's in Chapter 9 does not mean you are going to be responsible for all of Chapter 9, right? So just use your notes as a guide, because part of Chapter 9 we cover with muscles. Right? This part, we're just like, oh, this is how 2 bones come together, and that's what it's called. And the next part, we start wiggling it, and that goes with muscles. Good? Okay, so with classification of joints, first thing is that a joint is really a broader definition than we usually use for it. It just means the location at which 2 bones come together. That's what a joint is, okay? But some joints are wiggly and some are not. Let me give you 2 extremes. This is where my 2 parietal bones come together at this sagittal suture, and that's a joint. I sure as hell don't want it to wiggle, do I? No. Somebody smacked me in the back of the head and I get half a brain. I don't want that, right? That's a joint. But so is this joint, which is the wiggliest joint in my body right here, right? So there are different categories of joints, but basically with joints what you do is you have to it's a balance or a trade-off between mobility and stability, right? The more mobile you are, the less stable you are, because this one's the most likely joint in my body to dislocate, right? The more stable you are, the less mobile you are. Does that make sense? Okay, so we're going to do the joints in order of stability to mobility. We're going to start with the least wiggly ones and end up with the most wiggly ones. So the least wiggly ones are the ones that you see here. These 3 are all what we call fibrous joints. And what a fibrous joint has is bone, ligaments, bone. No cartilage, no fluid, no nothing in there. And they are not supposed to be very wiggly at all, okay? Classic example of a fibrous joint, and probably the tightest ones are your sutures, right? So your sutures are bone, ligaments, bone. And in addition to being that way, they're also serrated and interlaced so that they really don't move at all, right? In adulthood, right? So that's a suture. Some sutures happen so early in development that you can't even see them anymore. I told you guys before that we started out with 2 frontal bones, but it seals so early that you can't even see it in most people. But there are 2 other categories of fibrous joints. One of them is the joint that holds onto your teeth. Yeah? Those are called gomphosis. It's not supposed to wiggle, is it? No, not in adulthood. If your teeth are wiggling in adulthood, you need to floss more, right? Or you needed to floss more 10 years ago, right? So that's called a gomphosis. And then the other one, and this one's kind of weird, and it really only exists in this place. Well, mostly exists in this place. And that's the one between your radius and your ulna. In anatomical position, which one of those bones is lateral? Radius is lateral. Got it? Okay. There is a sheet that looks like a sheet of tendon, but because it's between 2 bones, it has to be ligament, right? Right? There's a sheet between them that kind of keeps them spatially in the same orientation of one another, even when they wiggle. And that's called the interosseous membrane, which is what it says, right? Interosseous. What does that mean? Between bones, right? Right? Between bones. This is a type of joint called a syndesmosis. Okay? Doesn't really exist very many places in the body. That's probably primarily where you're going to run into it. But all of these 3 have in common that there is no cartilage between them, right? And there is no fluid between them. When we get to the wiggliest joints, we're going to have fluid in the joint. So now we're going to move to the next joint. And the next joint is called, these joints are all cartilaginous joints because they go bone, cartilage, bone, right? And cartilage is a little wigglier than bone, right? So you've got a little bit more room for movement. Here's a classic cartilaginous joint. These are called the Costochondral Joints that attach your ribs to your sternum, and you can like wiggle them, right? You can't wiggle them this much, but you can feel them have some give, right? Those Costochondral Joints. So these are all called cartilaginous joints, but there's 2 categories of cartilaginous joints. If it's bone, hyaline cartilage bone, then it's called a synchondrosis. Okay, synchondrosis. And so the costochondral joints that we just talked about, those are synchondroses. But that also means that an epiphyseal plate is technically a synchondrosis, isn't it? Because it's bone, hyaline cartilage bone, isn't it? Yeah? Okay. So, and it is kind of wiggly and has a little give there. You're not very likely to damage it at the cartilage point. And then the other type of cartilaginous joint is bone fibrocartilage bone, and that's called a symphysis. And you've already met a symphysis, haven't you? This is the pubic symphysis. Yeah? Bone, fibrocartilage bone. But that means that these are symphyses as well. The fibrocartilage disc between your vertebrae. Does that make sense? Okay? So those are also symphyses. Okay? And they're kind of wiggly, but again, they're not this wiggly. Good? Okay, and then the most wiggly type of joint is this one. And this is called a synovial joint. Here's what a synovial joint has. Let's listen, okay? Bone, cartilage, fluid, cartilage, bone. And these are super wiggly. What do you think the function of the fluid in there is? Lubrication, reduction of friction, exactly, right? Okay, that's one of the major functions of it in there. So these are your super wiggly joints. You're primarily going to find these in your limbs because these are the wiggliest portions, right? Okay, I can't tell what joint that is. I don't even know what 2 bones those are supposed to be, but it's just random, any bones. So this is called a synovial joint because the fluid in here is called synovial fluid. Okay, so let's look at what a synovial joint is made of. So this is, of course, your bone with compact bone at the edges, and this is spongy bone, right? But what is this, by the way? Epiphyseal line. Yeah, epiphyseal line. Good. Okay, so at the ends of the long bones in a synovial joint, you have hyaline cartilage, But that doesn't make it a cartilaginous joint because, of course, it's got fluid. That makes it a synovial joint. The hyaline cartilage here is not actually surrounded with perichondrium because the fluid actually does the nourishing of the cartilage. Okay, so that's kind of unusual. Usually it's surrounded with perichondrium. Okay, what else do you find in here? This purple membrane that is lining any space that's not covered by cartilage is called the synovial membrane. And it looks like it would be epithelial tissue, but it's actually not. It's weird looking connective tissue. You don't usually find it on surfaces, but this is just a strange tissue that has secretory capacity. And what it does is it actually secretes the fluid into the joint cavity right there. And the fluid is called synovial fluid, and it's a real viscous fluid, like a thick fluid, because if the fluid is viscous, it can actually support the weight so that the cartilages don't ever even touch one another, right? If you have a thick enough fluid. Kind of like right after it rains, your car can like hydroplane, right? In which you've got this 2,000-pound car or whatever that isn't even touching the pavement, because what is actually keeping it afloat? It's not water, it's the oil, right? What happens is when you've got oil on the road, which is a viscous fluid, right? It can actually keep the car. So it doesn't just have to be a wet road. It has to be kind of a wet and oily road, that combination that you have. So this fluid in here is a thick viscous fluid that's made by the synovial membrane, and it secretes it into the cavity. And the fluid is lubricating, yeah? It's also nourishing to the cartilage, right? And as long as it's there, the cartilage doesn't rub up against the other cartilage. Somebody tell me why you don't want cartilage rubbing against cartilage. It'll wear down. And how good is cartilage at regenerating? It blows. Terrible at regenerating, right? So you want cartilage to be protected and not actually rub up against other cartilage, right? Reducing friction. Okay, so the other thing that you have in all synovial joints is a way to sort of attach the bones to the other bones. So the inner layer of the capsule or cavity is the synovial membrane, but the outer layer is what we call the fibrous membrane, okay? The fibrous portion or the fibrous capsule. Now, here's the metaphor for the fibrous capsule. Okay, imagine you got a soccer sock and you're going to pull it all the way over your knee, okay? And you are going to use that to sort of hold the two bones together and keep it structurally stable. What kind of tissue would you make that out of? Dense what? Dense irregular. That's what I would make it out of, and that's what it's made out of. The outer portion is made of dense irregular connective tissue. How do I assure that it has a really strong attachment to the bone? Well, the outer portion of the periosteum is dense irregular connective tissue, yes? So all I do is weave those collagen fibers into the collagen fibers of the periosteum, right? And there's not even a seam there, right? Because if your fabric is going to tear, is it more likely to tear at the seam or in the body of the fabric? The seam, right? So you just weave the fibers in to the periosteum, and it's a really, really strong continuous association. Does that make sense? Okay, so that's the outer layer, the fibrous portion of the joint capsule, and then you've got the synovial membrane on the inner portion. Now, how else can I reinforce this? I can reinforce this. It's not shown in this picture, but very often true, is that there is a ligament within the joint cavity attaching bone to bone, right? Ligament in there, okay, or 2 or 3, depending on where you are, right? And then you can also strap the outside of the joint with a nice strong muscle and a tendon, right? So if you're talking about your knee, for instance, part of the reason that, one of the ways that you can strengthen and make this joint a little less likely to be damaged is to strengthen the muscles around it, because you are going to strap the muscle over. Or for instance, if you have a back injury and it's not contraindicated, right? Do they tell you don't use your back?
They tell you use it.
Yes, they tell you to try to strengthen the muscles of your back and your abs to support the joint, right? Because the musculature and the tendons that are around it are helping to reinforce the strength of the joint. Does that make sense? Okay. And if this is the knee, this one actually isn't, the knee actually gets a little extra. One of the things that happens as you get development of the knee is that, and we can sort of see this developing evolutionarily, with the exception of the fact that the soft tissue doesn't fossilize. But one of the things that we see that is true in bipedal mammals versus quadrupeds is that, of course, if your if you're bipedal, it's harder on your knees than being a quadruped. Can we agree? There's like more stress on your knees. Okay. So we see with development of bipedalism in us and some other primates, including one of our cousins, not an ancestor, but one of our cousins, the bonobo, that as you become more bipedal, you develop 2 extra pads of cartilage. Lateral meniscus and medial meniscus, 2 pads of fibrocartilage. They're extra. In addition to all of that, stick one on this side and one on this side. And you can see those develop and thicken as you sort of develop bipedalism. Isn't that kind of interesting? So you can see them in bipedal organisms because we seem to need them. Okay, so here's your synovial joint. Now, just a little bit about joints in general. So there are a whole bunch of different categories of synovial joints depending on how they wiggle. I never asked you about these, but I'm just going to briefly introduce you to how much you could actually study joints. So synovial joints, of course, all most of them tend to be associated with the limbs, right? And they can do a bunch of different things, right? These are gliding joints, right? These are hingy. These are real hinge joints. That's all they do. This is a ball and socket joint, right? So there's different architecture to the joints. That's a hinge joint. That's a ball and socket joint. And depending on the architecture, it's either more or less stable or more or less mobile, right? Okay. The least stable type of joint that you find is this one, the ball and socket joints. Super duper mobile, but you compromise a lot of your stability with this mobility. Okay, so I don't ever ask you about those. It's interesting and we could do it, but I'd have to knock out something else. Okay, so last stuff on this set of notes, and then we'll start on muscles, is just to talk about arthritis. But I want to talk about arthritis more broadly than you usually meet that term. When people say the word arthritis, they usually specifically mean something associated with aging in joints, right? But if you break down the meaning of the word arthritis, what does it actually mean? Joint. Itis is inflammation. So it's a really broad term, inflammation of the joints. Inflammation of the joints can be associated with aging, can be associated with damage, can be associated with infection, right? Can be associated with any number of things. So let us be more specific about what we mean about arthritis. And first divided into 2 categories. We have acute arthritis and chronic arthritis. Acute and chronic, you with me? Okay. Now, you have an association with those terms. What does acute generally imply to you?
Not major.
Yeah, short term, you're probably going to get over it, right? And chronic is? Going to be with you a long time. Acute, gonorrhea. Chronic, herpes, HIV, yeah, right? One of them you're going to get over and one of them is like your buddy for life, right? It's with you. It's going to stay with you. Okay, so there are acute arthritises. I just made that up. So there are some forms of acute arthritis. I don't know. Acute arthritis is usually due to some kind of infectious agent. Some infectious agents like to attack your joints, and so they can cause an acute inflammation of the joint. If you take care of the inflammation before you have damaged the cartilage, then you're going to get over the arthritis. If, however, the inflammation lasts long enough to damage the cartilage, then you're going to have permanent damage, right? Does that make sense? Okay, so some examples. You guys know that Lyme disease causes joint problems, right? We don't really deal with Lyme disease here in the state because we're too desertified to have very many deer with Lyme disease and ticks. We don't have really, that's one of my favorite parts about moving to Utah from Texas, is that there are no fleas and ticks to speak of here. It's delightful. You should probably put that on a poster. If you want people to come here, it's fantastic. They're just all over Texas, all over the place. It's terrible. Lyme disease, it does a whole bunch of different things, but among them it can cause joint damage, either acute or if the damage occurs to the cartilage, chronic. Rheumatic fever. Rheumatic fever was the source of my heart problems when I was a kid. But it also can cause joint damage. And it's an infectious pathogen, and there are actually vaccines against it now. Yay, vaccines! And then TB, tuberculosis. As if you didn't have enough problems, you got tuberculosis, right? It also causes joint damage, right? Usually acute, and you can get over it. Okay, but most people are used to talking about arthritis as one of the chronic arthritises. Specifically, when people say arthritis, they usually mean osteoarthritis. Osteoarthritis is the type of arthritis that your grandma might have, right? But it's not only associated with aging. It is associated with wear and tear, which of course occurs with age, but also occurs with repetitive use, right? So osteoarthritis is associated with aging, but I can promise you that somebody who's a professional baseball pitcher is going to have osteoarthritis where? In his shoulder, yeah? And Serena Williams is going to get it where? She's going to get it in her elbow. And if you're a slalom skier, where are you going to get it? In your knees, right? Does that make sense? So it's repetitive use, wear and tear arthritis, and what happens is just repetitive use. The more use you have, the more likelihood for friction, right? Especially as you age, right? And if your synovial fluid doesn't keep up with the amount of use, then you're going to have a little bit of damage in the cartilage, right? And the damage in the cartilage can lead to these other factors. So what happens, and this one's pretty severe, what happens in these particular situations is you get degeneration of articular cartilage. But it's not necessarily the same in all of us. If Lauren and I were the same age, and we're not, obviously, if we were the same age, and I had more collagen in my cartilage than she did, then what would you predict for which one of us would be more likely to have osteoarthritis? Right. Does that make sense? Okay, so there's a genetic predisposition. It's not like you inherit osteoarthritis, but you inherit the amount of collagen that you have in your connective tissues, right? Okay, so now, as you age, you tend to have poorer circulation, right? So you're going to have poorer replacement of your synovial fluids and your collagen fibers and all of that kind of stuff. And so what happens is as you degenerate the cartilage, then what happens is the bone can push against the bone. And what does bone do when you physically stress it? Nope. It builds more bone. And what it does is it thickens and forms bony spurs, right? So this isn't just inflammation at this point. This is more bone tissue at that point. But when you get more bone tissue in a wiggly joint, what does it do to the mobility of the joint? Yeah, it decreases mobility of the joint, right? So you get this progressive decrease in the mobility of the joint with osteoarthritis. Who gets osteoarthritis? Males and females pretty much equally. Based on your genetic predisposition and at your age and your use of the joint, if you damage a joint, you're more likely to have osteoarthritis in it. Probably some of us have osteoarthritis in a joint or two. I've got it just in this little bitty joint. It's not even that big a deal, but my husband's a musician. I carried the speakers too damn many times, right? You see how big that joint is compared to the other one, right? Can't bend it all the way, can't straighten it all the way, right? So damage makes it more likely to have osteoarthritis. Go ahead.
I have, back condition and my legs wasn't great, and so I blew out all of my lumbar discs. And that caused me just like the pain and the immobility of it to like walk differently, and so now I have osteoarthritis in my hips.
Yeah, so you kind of radiate it. What?
Compensatory pattern.
Yeah, right, exactly. You radiate, when you're trying to avoid pain, you kind of radiate it to one other side, and anything asymmetrical is going to end up with some kind of manifestation later. It's really not uncommon at all for that to occur, and it occurs more likely with damage, of course. So what do you do about osteoarthritis? Well, most of the time you don't do anything except for treat the symptoms. You use anti-inflammatory drugs, right? First, over-the-counter, non-steroidal anti-inflammatories like aspirin, ibuprofen, and naproxen sodium and those kinds of things. Later on, you can of course get stronger versions of the same things, right? If it's really, really massive, you can use corticosteroids, which are really strong anti-inflammatories. But nothing actually cures the osteoarthritis. It just treats, the symptoms associated with osteoarthritis. There really isn't any cure for osteoarthritis once the damage has occurred. Okay, but more serious than osteoarthritis, which can get really damn serious, but this one tends to be really progressive, is rheumatoid arthritis. And rheumatoid arthritis is not particularly genetic, though you do see it popping up in families. It is an autoimmune disorder. It's a chronic inflammatory disorder. Autoimmune, meaning that your immune system makes a mistake and decides that your synovial membranes are the enemy and starts to destroy your synovial membranes. And as it does that, you don't produce synovial fluid. So what happens to your cartilage? Friction, right? Damage, bone spurs, but progressive. How progressive? I don't know. It's super variable from person to person. You can have the progression which goes so quickly that they decide to intervene with like chemotherapy drugs, right? Because it's going so quickly. Or you can have go into rheumatoid arthritis and go into remission, go into rheumatoid arthritis and go into remission. But like all autoimmune disorders, there's no cure yet for any autoimmune disorder. So this one is really serious. Here's what rheumatoid arthritis looks like. And you can have progressive degeneration and loss of functionality. And if your immune system just doesn't let up, then you lose functionality. It can even be life-threatening if, of course, it happens in your back and it causes such dramatic torsion that it's compressing your abdominal organs. Does that make sense? It can certainly be immobilizing and quite often is immobilizing. So over time, what happens is if your immune system won't let up on your synovial membranes, your body goes, well, I'm not going to make those anymore because you just keep trashing them and just put scar tissue in there, and then it's permanent, right? Just you can't get any synovial membrane back after the scar tissue has formed. So who gets this? Mostly women, not exclusively, but mostly women, usually in your 30s or 40s, although there is a juvenile form, juvenile rheumatoid arthritis, that occurs as early as 2 sometimes. Women are more likely to get all autoimmune disorders than men. There is a pretty strong hypothesis with a decent amount of evidence, but it's not conclusive quite yet, but you guys can, follow it as it comes along. And one of the hypotheses with some decent amount of evidence is that women probably get all autoimmune disorders more frequently because we are the baby carriers. The baby is half not you, right? Which is an immune system potential problem. During pregnancy, however, your immune system is suppressed so that you can maintain that pregnancy. But what happens more frequently than we used to know is that during childbirth, yes, there is some potential mixing of fetal and maternal blood. And that fetal blood, those cells, can actually take up residence in your body. And then if your immune system gets activated for whatever reason, right, it notices the foreigners and starts attacking where the foreigners go. How do they find this out? It's kind of an interesting story. I like this story. They had a woman that they were actually studying her genetics for a specific form of genetic skin disorder. I don't remember which one it is. And when they looked at her blood, they kept finding cells with Y chromosomes in them, which shouldn't happen generally in women. So they checked her for a chromosome abnormality, and she didn't have a chromosome abnormality. She just had these relatively infrequent cells with Y chromosomes, and then they did genetic matching and traced that Y chromosome to her son, who was 24, and then of course back to the dad, but it was her son's Y chromosome. And they're like, what the hell is going on? Well, apparently your children give you something. Sometimes that thing that they give you actually helps you through immune system situations, but sometimes when your immune system goes awry, it starts to notice those and attack those. But it's interesting because we need a good control population to study that, right? So for not the first or the last time, the Catholic nun population, most of whom do not have children. You can become a Catholic nun after you've been a mother, but most of them don't have children and have never had pregnancies. They have volunteered again and again to be the control population for this particular. So for instance, Catholic nuns who have never had a pregnancy actually have the same predisposition as most women in their 30s and 40s. As of now, it seems as if they don't. They have about the same predisposition as a man does. So that's our initial sort of findings with that. We'll have to see what happens over time when they study all of the autoimmune disorders. Why 30 or 40? Well, because that's generally your pregnancies occur, teens to mid-30s, right? That's when most of them occur, right? So the autoimmune tends to happen after the pregnancy occurred. And interestingly, you don't even have to carry the baby all the way to term. Seems as if into the 3rd trimester is enough, especially since into the 3rd trimester you are going to, even if it was not a live birth, you are going to have the potential for exchange of blood between those.
Another reason why babies mess up our bodies, right?
Yeah, they do. But there's actually some interesting things. There's I always talk about that, and I'm like, okay, so you need to buy your mom a present, right? But also, interestingly, we thought it was all negative, and there was another study that showed that actually your kids actually provide you with some extra genetic diversity to get through a lot of pathogenic infections. Women are more likely to live through almost any damn thing than dudes are, right? Almost anything, right? We get more diseases but we still outlive them, right? We just do. We outlive them, usually by 5-7 years. Outlive men. Okay, it's probably to make up for the fact that you didn't pay us enough when we were alive. So, okay. All right, so last little tidbit is, what do you do? Oh, a little bit more about this one, sorry. Where does this one hit? Usually small joints first. And usually for reasons I don't understand, nobody does yet, it's almost always symmetrical when it hits. So if you get it in your right wrist, you get it in your left wrist. What the hell that has to do with anything? I don't know. Just makes it sound like your immune system is OCD, right? Definitely both wrists, definitely. And this is really, really severe, and it can be totally debilitating. When I was in grad school, I was maybe 26 or so. I had an undergrad assistant, and I think she was 18 or 19, I can't remember. And she had rheumatoid arthritis, and she was already starting to lose mobility in her hands, and it was progressing so quickly that her entire objective was to finish her bachelor's degree before she was immobilized and wheelchair bound. So it was really, really progressive with her. So what the hell do you do about this? Well, depending on how severe it is and how life or quality of life threatening, they treat, of course, the inflammation. You can use corticosteroids like prednisone and those kinds of things, of course, right, to reduce inflammation. You can also use the over-the-counter. Those usually won't do a damn thing to rheumatoid arthritis. But then corticosteroids, surgical interventions, if it starts to reduce mobility such that, you're compressing your abdominal organs, it's not going to fix anything though. And then in serious situations, like if you have it when you're relatively young and you really, really want to stop it, they will use chemotherapy drugs to kill off your immune system to allow you to stop the progression of the disease. But I mean, there are risks, of course, associated with killing off your immune system, right? To really, really be careful about exposure when you do that. Does that make sense? Okay, so that is rheumatoid arthritis. And then the last one is gouty arthritis, also just called gout. Have you guys heard of gout? Okay, so gout is an interesting one. Gout is, so here, you ready? Gout. What happens, and this is also gout, and this is also gout. What happens with gout is it's kind of a metabolic disease that can be exacerbated by your diet. Okay, so all of us eat organic molecules in order to stay alive. Fats, proteins, nucleic acids. We don't usually think about using those as macromolecules, but of course we eat them, right? Because you eat DNA of RNA of every damn thing you eat. And carbohydrates. Well, when we have really protein-rich diets, they also tend to be really nucleic acid-rich, okay? And one of the byproducts of lots of nucleic acids in your diet is this nitrogenous waste product called uric acid, okay? Most of us eat it, clear it through our kidneys, all is well and good. Some of us produce too much. Some of us don't clear it very regularly, uric acid, okay? When it elevates in concentration in the bloodstream, it tends to crystallize. And for whatever the hell reason, it likes to crystallize in your synovial joints. So now think about doing this and this with sand in your joint. Think about all the pain that occurs with doing that, right? Okay? So they used to call this the king's disease or the rich man's disease because historically speaking, if you think back to let's think about the Dark Ages or the Middle Ages in Europe, right? Who got a high protein diet? Rich people. And be more specific. Rich men, yes. Okay? So men were more likely to get it historically speaking, and the more wealthy, the higher protein diet. Now that doesn't make sense. Just think about, of course, how people historically would have eaten. Grains would have been your staple if you didn't have a whole lot of money because you didn't have a lot of animal products, right? In Europe, probably wheat. Here, probably corn. In Asia, probably rice. But grains of some sort, right, would have been the staple. And then meat wasn't abundant for most people. So they called it the rich man's disease. But now, especially like in this country and most Western countries, even if you're not wealthy, you can have access to a relatively high protein diet. It might not be good quality protein, right? But it's still relatively high protein. So it's become a more egalitarian disease. Just like anybody can get it now. Because you can be poor and get a whole table full of Taco Bell for $12, right? it's crap food, right? But there's plenty of protein in it, right? There's plenty of protein. So gout, what do you do about gout? Well, this is mostly men still, but women are catching up with gout. What do you do? Well, you can change your diet. How likely are people to change their diet when their physician tells them to? I mean, you've been to Walmart, right? You know that those people are not listening to their doctors, right? You've seen the woman who's 25 years old and running around on a little scooter, and you're like, what the hell's wrong with you? And she's like, I just decided to be fat. That is what's wrong with me, because I'm going to ride a scooter, and I'm 25. So they're probably not going to change their diet. What they need to do is increase their water consumption to clear the uric acid out, decrease their acid consumption, because there's like if you drink a lot of sodas, it makes it more acidic, it's more likely to crystallize, and reduce your protein consumption. But most people just want a treatment, and the treatment is you need to either reduce the production of or increase the secretion of uric acid, and there are some drugs that do that, like colchicine does that. So anyway, that's gout. Now we can all get gout. What? Yeah, alcohol does increase the predisposition for gout, and I think, not sure about this part, I think that the phys related to that is that it tends to, alcohol is a,
Well, I was saying that I don't drink soda, so I'm superior.
Oh, okay, sure, yeah. I'm sure we all have reasons that we're superior. Alcohol dehydrates you, and so it makes all of the solutions more likely to be concentrated. So I think that's the primary relationship. It might do something to the acidity, too. Okay, but I can't quite remember that relationship. Okay, so that's the end of the notes for test 1. Yeah? And now we are going to briefly, well, not briefly, but we're going to spend a decent amount of time on the next set of notes. Don't disengage now because this isn't going to be on your first test. What it will do if you pay attention today is make it less likely that you cry when you have lab next week. Okay? Because there is a logic to this, and if I start to give you the pattern before somebody tries to get you to take a drink from a water hose of muscular knowledge, right? Then you've got some patterns and you can start to organize things and you won't be as overwhelmed. Does that make sense? Okay, so that's my objective today. So when we do muscles, first off, it's going to be a long time before you are tested for me for muscles. So you have lots of time to absorb it. And I'm not going to give you a quiz over muscles, obviously, until you've already had your test for this and you've already done muscles in lab. So you won't even have a quiz over muscles until like week after next. Okay, so you got some time for absorption. Note to self that there, with muscles, there's quite a few chapters, but kind of the same thing as skeletal system. So chapter 9 is the rest of joints, right? Only now I'm going to talk about how they wiggle. She's going to regret that so badly. Now I'm going to talk about how they wiggle. Okay, I'm going to wiggle the joints. Chapter 10 is muscle tissue, and it will directly correlate to physiology, right? That's the information that you need to sort of understand muscle function when you get to physiology. Chapter 11 and 12 are the chapters that you're primarily going to use with lab. Chapter 11 is axial muscles, and chapter 12 is appendicular muscles. It's like where they all are and how they're organized and what they're attached to and everything. Everybody okay? Does that make sense? Okay, so today what I'm going to try to do is try to teach you sort of the logic and the physics of how muscles work. My objective is to reduce your stress and reduce the amount of memorization that is necessary for lab. Does anybody have their lab book with them? Yeah? If you do, I want to see a lab book and I'll show you something and how this relates to what you're doing in lab. I just need one. Okay. Okay. All right. So you're gonna want to cry next week, but don't do it. Okay. So next week, when you start getting to muscles, you will see that. Okay. For instance, you're going to learn between the 2 weeks. I think there's 93 muscles that you learn. But it's not just 93 muscles. It's 93 muscles and what everyone does, which is 93 times 2, right? And the attachment point for many of the 93, but not all. Why not all? Well, because I'm not going to make you learn an attachment point if I didn't make you learn that part of the skeleton, because then it's just arbitrary, right? But for instance, where do you think the deltoid muscle attaches on the humerus?
Tuberosity.
The deltoid tuberosity, right? So I can make you learn that one, right? Because then it'll reinforce what you actually learned. So the stuff that I'm going to teach you today will help keep you from having to memorize all of these 3 columns, because the actions will make sense when I teach you the logic and the physics of how muscles work, right? Okay, so there is a logic to it, and you have direct correlation to the stuff that we're doing on this column. Okay, so hold on for a second. I might use it again. Don't fall. Okay, so first, before we get into the specifics, I want to teach you just a little bit about terminology and a little bit about how muscles are like stuck to your skeleton. So first thing is simply knowing that anytime you see the prefix MYO or the suffix MYS, it means muscles. So if, for instance, you run into a covering called the perimysium, oh, that goes around the outside of the muscle, right? Okay, so we're going to run into that quite often. So before we get into the specifics, I want to talk about how muscles are attached generally to the skeleton. Not all your muscles are attached to the skeleton, but some of them are. And this one is, of course, the biceps brachii. I'm going to use that, but I'm going to start with the simpler one. I'm going to start with the deltoid muscle right here. Okay, so the way that muscles work, and this is important because it will help you to predict and reinforce with lab instead of memorize. Muscles are attached to generally the skeleton at least 2 points, right? And one point, when the muscle contracts, will stay stationary. It's holding down the fort. And the other one, when the muscle contracts, will move. And the way that it moves is it moves closer to the first one, okay? So really, all I'm doing with muscles is yanking on stuff. All muscles ever do is pull. They cannot push. They pull. Okay, so deltoid right here, okay? There is a fixed point of attachment that generally doesn't move. That's called the origin. You with me? And then there is a point of attachment that when the muscle contracts will move closer to the origin. And that's called the insertion. Does that make sense to you? Okay, good. Origin, insertion, insertion. Okay, so we're going to practice this quite a bit today and have you like try to figure out based on a movement which one's the origin and which one's the insertion. So the important thing for you to understand, muscles only pull, they never push. That means that, watch this movement, ready? It's the same movement that he's doing. I'm going to do it this way. Okay, muscles only pull, they never push. So if I do this action, okay, think about the physics for a second and tell me where the origin is approximately. Just touch on your body, right? It's up here somewhere. And the insertion is where? Okay, now, here's what a lot of students do. They don't understand that you have to cross a joint to move a joint. And they will insert right here. Can we all agree that you can't yank on the forearm unless you're attached to the forearm? Right? Okay, so you have to cross a joint to move a joint. You with me? Okay, but can we also agree if the physics only pulls, never pushes, right? That I cannot do the opposite movement with the same muscle. Do you agree? So if this was the movement I was talking about, I cannot use this muscle to do that movement. Yes? Because you're just yanking on stuff. So now, muscles are generally arranged in pairs around a joint. One of them will wiggle it one way, and its buddy, called the antagonist, right, will wiggle it the other way. Okay, so let's do that one more time. You ready? So I'm going to do this, yeah? Okay. Where is the muscle that's responsible for doing the opposite? On the back side. Where's the origin? Up here somewhere. Where's the insertion? Down here somewhere. Got it? Okay. So muscles are arranged in what we call opposing pairs or antagonistic pairs, right? You're going to have another one on the other side in order to do the opposite because muscles only pull, they never push, right? And then the other rule, if you're going to move a joint, what do you have to do? Cross the joint. Yes? Good. Go ahead.
Are the origins of those two usually the same?
They don't really have to be. We'll talk a little bit about how origins are going to be. So in order to do this, I can have the origin right there, right? If I wanted more range of motion, I have it further out. Gives me a little more, like, a short rope doesn't allow you to do quite as much as a long rope. So you can put it here, yeah? And there is a muscle called the brachialis that just goes here to here, yeah? Or you could have this one, which is called the biceps brachii, and it goes all the way up onto the clavicle and scapula. Does that make sense? Okay. If you cross two joints, you might have a little action at both. Is that okay? Okay. Got it? And we're going to reinforce it as we go through. Okay? Okay, you understand the basic plan? So you're just yanking on stuff. That's all you're doing. You're never pushing anything with a muscle. You're always pulling. Okay? So We've got agonist and antagonist, and then sometimes you have a friend. So muscles are arranged in pairs. The one that does the action that you're talking about, if we start with this, right? Whatever action you talk about first, the one that does most of the work for that is called the agonist, or the prime mover. The one that does the opposite to that is called the antagonist. Got it? And sometimes the agonist has a helper. So if I say, I'm not telling you this is true because you'll find out that it's a little different than this. If I say that the biceps brachii, which everybody is familiar with, is the agonist for this movement, it's got a deeper muscle right there called the brachialis, which is the synergist. It's a helper, right? You generally don't have to know which one's the agonist and which synergist. The one that does most of the work is the agonist, and it has a little helper. Here's an example. This movement right here, okay? Elevation of the jaw. You with me so far? Okay. See if you can figure out, before I tell you the whole agonist, synergist, and antagonist thing, where the muscle is attached to do this. I'm going to go ahead and tell you it's right here. Where's the origin? Remember, you're pulling. Go ahead. Go ahead. Where's the origin? Up here. Yeah? Where's the insertion? Just pull on it. Yeah? It's on your mandible, right? So the origin is on your zygomatic arch. Yeah? And the insertion is on your mandible. With me? Okay? Right? But it has a helper. And its helper has its origin way up here in the insertion on the mandible. It's not very strong, but it adds a lot of range of motion, right? So not only can you do this, but you can go all the way from open and close it all the way up, right? Does that make sense? So this one's a helper. That's the synergist. Okay, now see if you can figure it out. I just did this motion. I want to figure out where the antagonist is, or else I'll have to stay like this. Where's the antagonist? Do the opposite motion. Okay, origin approximately somewhere. Where? See if you can do it. Just pull it down. Figure out where you have to pull from.
Feels like around my ears.
You have to pull down. Down here to here. Do you see how that physics works? Origin down here. Does that make sense? Okay. So you're just pulling it one way, and then you figure out how the physics works to pull it the other way. Yes? So that muscle is actually in your neck. Yeah. You feel it? Yeah? That muscle. Good? Okay. So that's agonist, antagonist, and synergist, right? So now with that in mind, what I'm going to do is I'm going to try to teach you the beginnings of all of these body movements at synovial, mostly synovial joints, because synovial joints are your wiggliest joints, right? So most of these movements are going to be at synovial joints. And these body movements are going to correlate directly to the action column that you're going to talk about in lab. So the body movements and the actions, since the action doesn't do you a damn bit of good to read, if you say, okay, the rectus femoris flexes the thigh at the hip joint and extends the leg at the knee joint. Doesn't do you a damn bit of good if you don't know what flexion or extension is. Doesn't do you a damn bit of good to know that the sartorius flexes, adducts, and laterally rotates the thigh at the hip if you don't know what any of those things mean, right? So we are going to learn the body movements today that correlate directly to the action. So what's the difference between a body movement and action? Flexion is general. The action of this muscle is flexes the bone at the blank joint. Okay? Flexes the thigh at the hip joint. Got it? Okay. And that's how we're going to practice. We're going to practice doing that today. And it won't make the most sense today, but give yourself a little time and it'll sink in there, percolate through your, like groundwater. And then you'll start to get it, especially as you start practicing it in lab next week. Okay. So we're going to start with the body movements that are first called angular movements. And angular movements means starting from anatomical position, I'm going to change the angle between two bones, right? I'm going to change it this way or I'm going to change it this way. That makes sense? Okay? So the first of the angular movements is called flexion. When you flex something in the gym, it's a really general term. That is not what it means in anatomy. Flexion means something very specific in anatomy, okay? Flexing any muscle is just like engaging the muscle, right, in the gym, right? Here it means something different. What flexion means here is decreasing the angle between two bones, okay? starting from anatomical position. So you have to know anatomical position first, right? And now I'm going to do something to these two. You have to know a little geometry. What's the natural angle of these two bones approximately? 180, yeah, right? Decreasing the angle. That's flexion, okay? This is putting it back. The opposite of flexion, the antagonistic movement, is extension, yes? Extension is increasing the angle, which is usually just replacing it to anatomical position. Is that okay? Okay, so I'm going to do a couple things. You tell me whether I'm doing flexion or extension. You ready? What am I doing?
Flexion.
Flexion. What am I doing? Extension. If you go past anatomical,
Extension.
hyperextension. You can't hyperextend every joint, but you can with some. Okay? Okay, ready? What am I doing here?
Extension.
Hyperextension, extension, or hyperextension. What am I doing? Don't pay attention to my knee. What am I doing here? Flexion. Yeah? Okay, that makes sense? Now, the knee cannot flex anteriorly. It just can't, right? It only flexes one direction, but it is still reducing the angle, isn't it? That's flexion. That just has to do with us basically being quadrupeds evolved from bipeds. Bipeds evolved from quadrupeds. Does that make sense? Okay, so I want you guys to see if you can figure out how to flex your wrists. Start in anatomical position, flex your wrists. Extend your wrists, hyperextend your wrist. Got it? Okay. Now the shoulder's a little harder because it doesn't look like flexion because you can't see the bone continue to go. But what am I doing here? Flexion. Yeah? What am I doing here? Okay, what am I doing here?
Extension.
Hyperextension, flexion. If I go back to here, it's extension. If I go past anatomical, it's hyperextension. Got it? Okay, everybody good? Okay, so you can't hyperextend every joint. Some just aren't that mobile, right? So now let's talk about flexion in a little bit more detail, show a couple of animations. With these animations, I want you to look at the action, confirm that it looks like flexion, and I want you to try to figure out where the origin and the insertion are, okay? You're going to see two attachment points and try to figure out which one's which. Okay, so let's do this one first. Ready? Okay, this is flexion of the blank at the blank joint. Flexion of the forearm at the elbow joint. Does that make sense? Because you're being more specific than just saying flexion. Okay, so now tell me, just touch, you don't have to know specifics yet. Where's the origin and where's the insertion? Origin is more proximal, yeah? It's up here on this one. And the insertion is more distal. Does that make sense to you? Right? Now, the reason, why am I going through this? I'm going through this because once you have a little practice about this, you will figure out that if you know the action of a muscle, you can tell which one's the origin and which one's the insertion. You don't have to memorize it, right? Does that make sense? How about if you know the origin and the insertion? Do you have to memorize the action? No, because if you know the origin and the insertion, then the action is to pull the insertion closer to the origin, right? Does that make sense? That might not get you every single one of the actions, but it'll certainly get you one. Does that make sense? So basically, if you do this right, this is logic more than memorization. And there's always going to be some memorization because you have to not just wiggle it, you have to get it to the specific point that it's actually attached to, right? But if you know, right, the logic, then you can tell when you wrote something that's complete crap. You're like, that doesn't make any logical sense. Why the hell did I write that, right? So you can tell when you write something that's just absolute nonsense, okay? So that's flexion. This one's harder. Okay, so this is also flexion, and I want you to think about attachment points. Where's the origin and where's the insertion for doing this? Yes, so that is this motion right here, right? Where's your origin? Pubic symphysis. Where's your insertion? Sternum and ribs, yeah? Okay. A lot of people like to flip those, but that would be this motion, which is awkward for everyone, right? That's not what it really does most of the time, right? Okay. So this muscle, anybody know what this muscle is? Rectus abdominis. That's the rectus abdominis, and you'll learn it a week after next. Okay. Everybody good? Okay. So that is flexion. Let's talk about extension. Okay. So extension is generally putting whatever it was back to anatomical position after flexing it, right? So this is flexion, this is extension, right? Okay, what am I doing at my knee? Flexion. Now what am I doing? Extension. Okay, what am I doing at my hip? Flexion, extension, hybrids. Okay, so let's talk about this. Flexion versus extension. So let's go back to that and make sure that we kind of understand the logic here. Generally, you are going to find a muscle responsible for flexion on the what surface of a joint? Anterior, with one notable exception, and that's the what? The knee. Good. Notable exception is the knee, right? Because that one's just like flopped around, right? Now, extension is the opposite. So generally, you're going to find a muscle responsible for extension on the what surface of the joint? Posterior surface of the joint. So now I'm going to show you in action, and I want you to tell me where the muscle is that does this, okay? So you told me this was flexion at the hip, yeah? Okay, where's the muscle? Have you ever heard of hip flexors? Yeah, that's what those are. Now get it back. What muscle is going to bring it back?
Glutes.
Yeah, glutes are going to bring it back. So those do extension at the hip, right? All right, here's a little bastard that you're going to hate when you're on lap. You ready? You got a group of muscles that starts here, crosses the hip joint on the anterior surface, and then crosses the knee joint on the anterior surface. These muscles can do what at the hip? Flexion. And they can do what at the knee? Extension. Yes, yeah? Those are the muscles that allow you to, right? If you cross it, right? So it's not memorization. If it's crossing the anterior surface, it's more likely to be a flexor. Yeah? Okay? So there's some logic to it. All right, so I'm going to show you an animation about extension. I'm going to ask you different questions, this one. With this one, I'm going to say, okay, this is extension. You're going to tell me where the origin of the insertion is, and then you're going to tell me this muscle is an antagonist to what muscle? Okay, one that we've already seen. Ready? Okay. This is extension. Oops, damn it, Melanie. It's going to be extension in a second, as soon as I stop being a knucklehead. Okay. Okay, that's extension. Everybody good with that? Where are the origins? Yeah, they're way down low, right? Sacrum, iliac crest, down there, okay? And then where are the insertions? Up on the vertebra and the ribs, right? Okay, all the way up to the skull. This muscle is an antagonist for a muscle we've already seen. Which muscle? Yeah, it's an antagonist for that one, right? Does that make sense? Does this make sense with the whole pulling stuff around idea that I gave you, right? So these are called the erector spinae muscles, and they extend the vertebral column. What does the rectus abdominis do? It flexes the vertebral column. Extend, flex. Got it? Okay. So, everybody okay with that? Okay. All right. So now let's do a different kind of angular movement called abduction and adduction. Okay. With abduction and adduction, what you're going to do is you have an imaginary midline, and you're going to move further away or closer to it. If you abduct, as in to kidnap or take away, you move further away from the midline. If you adduct, you add it back. Abduct, adduct. You can also abduct here, adduct here.
So can you
Yeah?
adduct and adduct?
That's rotation. I'll teach you rotation in just a second. It feels different. By the way, I know it's nerdy. If you move your body, you are more likely to remember these actions, okay? So abduction of the what bone at the what joint am I doing? At the humerus, abduction of the humerus at the shoulder joint. That's what I'm doing. What am I doing here? Abduction at the hip joints. Yeah, and sometimes they don't say femur, sometimes they say thigh, right? But you got to get a region or a bone that you're moving. Does that make sense to you? Okay, so that's abduction. This is not abduction. The neck has its own special words associated with it. And this is a little counterintuitive, but this, watch my hands, this is actually abduction because I'm using this as the midline, right? Good? Okay. So in most situations, this one accepted, you're going to find a muscle responsible for abduction on the what surface of the joint? Lateral, yes? Lateral surface of the joint. So the muscles responsible for abduction on my hip are right here, yeah? Where are the muscles responsible for adductions, or else I can't put it back? Right here, yeah? Pull them back in. Got it? Okay. Now, this is, like I said, abduction of the hand. Do not be surprised next week when you run into a little muscle in the freaking forearm that's going to make you want to cry. One of the muscles is called the abductor pollicis. Yes? Pollicis, because what's it doing? It's abducting the pollicis. And then you've got a short one and a long one, so you're going to have an abductor pollicis longus, abductor pollicis brevis. Got it? So there is a bunch of logic, and you just sort of know the actions before you actually get into there. That's not what you're going to be focusing on the first day. You're going to be focusing on the first day, what the hell, this cadaver is crazy, and why the hell didn't I drop this class? Right? But no, you can pass that part. It'll be good. Okay? So that's abduction, movement away from the midline, and let's look at it. Animation of abduction. So this is, of course, abduction using the deltoid, and you should be very comfortable right now knowing which one's the origin and which one's the insertion. Origins where? Here. Insertions, deltoid tuberosity of the humerus. That's where it's going to be. Okay, you don't know that yet, but it makes sense that it's going to be there, right? Okay, all right. So adduction, where are you going to generally find a muscle responsible for adduction? Medial surface of the joint. Now, this one's a little weird, so don't let this confuse you because it can get confusing. When I do adduction of the arm at the shoulder joint, this is primarily my deltoid muscle, right? But I don't have any muscles here. That's why it's so easy to dislocate, okay? But does it make sense to you that I can actually attach one here to here and do adduction, or here to here and do adduction? So don't be surprised when, for instance, one of the functions of the pectoralis major is adduction, right? And one of the functions of the latissimus dorsi is adduction. So it doesn't have to be exactly on the opposite side, but the physics has to work so that you're pulling it, right? Does that make sense? Okay, so that's adduction. And then one last angular movement, and then we'll move into rotational movements. This looks like it's rotation, but it's not. I'll explain to you why in just a second. This is called circumduction. Circumduction is for ball and socket joints. It's a complicated movement, and it's basically making a cone in space, right? Making a cone in space, okay. But really doing that is just 4 different movements in series, isn't it? So tell me what movement I'm actually doing when I isolate it. Flexion, abduction, extension, adduction. Yeah? Right? So really it's just that complex movement. It generally means that you have to have muscles on all 4 sides, right? So you can do it at your hip as well. Not as much range of motion, but you can do it at your hip as well. Is that okay? Okay. So now let's do rotational movement, and then we'll do the other ones. Okay, so rotation, I want you to do this because if you don't feel it, it doesn't look, if you just watch it, if you can't figure out what's happening. So here we go. We are going to try to rotate our humerus around its own axis. It's going to look like, when I do this, like I'm moving my forearms, but that's not what I'm trying to do. They're just following my, my humerus. Okay, so I'm going to start in anatomical position. What I'm going to do is I'm going to rotate my humerus laterally. Feel it? You should feel a stretch across your chest and a tightening in your back. Does that make sense? Okay, that's lateral rotation. Go back to anatomical position. Medial rotation is taking the humerus and rotating it medially. You should feel a stretch across your back and a tightening in your chest. Does that make sense? Okay, so let's talk about how you do that. Let's do lateral rotation first. Lateral rotation. A muscle that is going to be responsible for lateral rotation is on the what surface of the torso generally? Posterior surface of the torso, insertion onto the limb. If you want much range of motion, you don't insert it back here, you insert it over here so that you can have some more leverage, right? Okay, that makes sense? So muscles responsible for lateral rotation start at the backside, go onto the limb, right? That means that muscles responsible for medial rotation do what? Start on the front side and go onto the limb. Again, if you want more range of motion, insert it further over. Yeah? Lateral and medial rotation. You can do it at your hip, but you don't have as much range of motion. A little bit of lateral rotation, a little bit of medial rotation. Right? That makes sense? Okay. So that's lateral and medial rotation. It looks like you're just flipping your forearm. That's why you kind of have to feel it, because flipping the forearm is a different action than actually doing this, right? Okay, all right. So other movements. Okay, now let's talk about what flipping the forearm actually is. That's a special movement that you can only do right here. Anatomical position, the forearms are parallel to, the bones of the forearm are parallel to one another. Okay, but then you can cross them over one another. Parallel, crossover, parallel, crossover. Where am I actually moving? Wrist, elbow, what am I moving? Elbow. I'm moving my elbow, right? That's where the muscles are. It feels like a wrist if you're just looking at it, right? But it's actually the elbow that's moving, okay? And what that motion is if you end up so that you can drink some soup, you just supinated. If you end up so that you just poed out your soup, you just pronated. Supinate, pronate. Supinate, pronate. And those muscles are going to cross here. Yeah? You're going to have a supinator muscle. It's going to be crossing the elbow, right? Okay. All right, so special movements at the ankle with our last couple of minutes. Let me show you these real quick. Stand up here. I'm not going to step on your stuff so you can see my ankles. Okay, ready? All right. Dorsiflexion and plantar flexion. Somebody named those wrong because that's making flexion the opposite of flexion. But we just have to get used to it. Okay? So dorsiflexion and plantar flexion are movements at the ankle. You name them for the surface that you flex toward. Listen to that again. You name them for the surface that you flex toward. So now I'm going to do one, and you tell me whether I'm dorsiflecting or plantar flexing. Dorsiflecting, because that's the dorsal surface of the foot. Yes? And now what am I doing? Plantar flexing. Got it? Dorsiflect, plantar flex. Okay, now tell me where the muscle is that's responsible for dorsiflexion. Not your calf. Anterior surface, yes? Put it here, here, yank. Yes? Where's the muscle responsible for plantar flexion? Calf, yes? Here, here, yank. Yeah? That makes sense? Okay, that's dorsiflexion and plantar flexion. And then last one, before you guys leave, is inversion and eversion. These are slight movements at the ankle, but they make it really possible for you to walk on uneven surfaces. So eversion is taking the sole of the foot and pushing it laterally. Yeah? Inversion is taking the sole of the foot and pushing it medially. Tell me where the muscle responsible for eversion is. I just did it. Lateral surface, yanking. Yeah? Where's the muscle responsible for inversion? Medial surface, yanking. Got it? Okay? Good? Okay, so that's most of them. The other ones you will get in lab. We did most of the hard ones and most of the ones that you're going to run into during the first week of lab. And then we'll pick up the other ones the next time. Okay, so I will see you guys on Tuesday. You're going to bring your device, right? Because there's 10 top hat questions. You don't need to bring an answer sheet. Good luck studying. What? 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 Oh, there is. 24 questions due Sunday night.
And then there's another one in class.
No, that's just part of your test. The top hat one is just review. Like how well is your studying going? The one, the 10 questions are just 10 histology images, so you can actually be tested over those. By the way, I want to be clear, that doesn't just mean you're going to have 10 histology questions. Yes? There's just 10 color histology images, and then there's lots of word questions. Yeah?
How many questions again, Melanie? Is it?
I don't know, I haven't written it yet. Maybe, no, probably like 60-ish.
Okay. I was just curious.
You got 80 minutes to do it. 60 or 70 questions, something like that. See ya.
Is that a word?
Thank you.
See ya.
Yeah.
They are floofy.
Yeah, he doesn't think it's a real word.
Can I talk to you about the first quiz I grade?
Oh yeah, I just need to change it in Canvas. Give me a second.
Yeah.
This is